Hi, my name is Adam Faye, and I'm an advanced IBD fellow here at Mount Sinai in New York City. I wanted to thank you so much for inviting me to do IBD Journal Club for February 2021. So today we'll be briefly discussing a recent article that was just published in the American Journal of Gastroenterology entitled "Location but Not Severity of Endoscopic Lesions Influences Endoscopic Remission Rates in Crohn's Disease." And this is a post-hoc analysis of the TAILORIX trial. So let's briefly discuss the TAILORIX trial. So this was a randomized controlled trial to determine whether therapeutic drug monitoring to maintain infliximab levels greater than 3 would lead to higher rates of clinical and endoscopic remission. So they had 3 arms. In the first 2 arms, it was based on clinical and biomarkers. And the first arm was dose increased by 2.5 milligrams per kilogram, whereas the second arm was dose increased straight from 5 milligrams per kilogram to 10 milligrams per kilogram. The third arm, which was considered the control arm, was actually dose increased from 5 to 10, but based only on clinical symptoms, so not based on biomarkers. And the primary endpoint was looking at corticosteroid-free clinical remission, defined as a CD activity index less than 150 from weeks 22 to 54, with no ulcers at week 54, as well as no surgical intervention required, etc. So when we look at the results, what we see is that in group 1, 33% of patients actually met the primary endpoint versus 27% in group 2 and 40% in group 3. So we can see that there's really no statistical difference between the 3 groups. So let's briefly review background. We know in Crohn's disease that endoscopic remission leads to fewer hospitalizations and surgeries, so we're always aiming for this. From the VERSIFY trial, which was looking at vedolizumab in Crohn's disease, we know that higher rates of mucosal healing were seen in the colon than in the small bowel. So from that, the objective of this study was to look at the impact of, again, combination therapy, which was infliximab and immunomodulator, on endoscopic healing when we look at both the location of disease and also severity of disease. So in this study, it was a post-hoc analysis of the TAILORIX trial. It had 122 bio-naive patients with Crohn's disease and visible ulcers who were requiring initiation with biologic therapy. Each patient had 3 endoscopies at baseline, week 12 and week 54. And in this study, they stratified by both severity and location of disease. For severity, they looked at very large ulcers versus smaller ulcers, and they also looked at depth, deep versus superficial. For location, they looked at segmental remission rates, specifically looking at the ileum versus the colon versus the rectum. And it should be noted that data imputation was used for patients that were missing endoscopic data. So looking at baseline characteristics, I'll draw your eye to 2 different items. So 1, looking at those patients that had ileocolonoscopy at week 12 and 54, we do see that 27 patients were missing some data at least. And when we look at Crohn's disease location, we can see that the majority, 58%, had ileocolonic disease. So let's first take a look at severity of disease. So this is a very beautiful alluvial diagram, and we can see that at baseline, week 0, 2/3 actually have deep ulcers. And you can follow to week 12 and week 54, both the proportion that have deep or superficial ulcers, and also you can follow the path of each. So let's take a look at the median CDEIS scores. What we can see is at baseline, week 0, those with deep ulcers have a higher median CDEIS score as opposed to those with superficial ulcers. And we can see that this is statistically significant. When we actually look after initiation of therapy, so week 12 and week 54, we can appreciate that these medians now are fairly similar, and even the outliers are. So no longer is there statistically significant difference. When we look at size of the ulcers, we actually see very similar results. So at baseline, the endoscopic score is higher for patients with very large ulcers as opposed to those with smaller ulcers. But when we look at week 12 and week 54, again, after initiation of therapy, we see that the median value endoscopic scores are fairly similar, as are the interquartile ranges with p-values that are not statistically significant. Interestingly, when we look at segments of disease, though, we do see that it is more difficult to heal the ileum. So at week 12 and week 54, we can see that 45% and 59% respectively have endoscopic remission, but this is in comparison to much higher numbers within the colon and the rectum. So this is statistically significant, at least between the ileum and the colon and rectum, but between the colon and rectum, there did not seem to be a significant difference. So what can we conclude from this study? Well, first, strengths. Even though it is a post-hoc analysis, it is based on RCT data, which is always the gold standard. It was a multi-center trial, and it did allow for 1 year of follow-up. terms of limitations, however, there was only a central reader in place at week 54, and at least 22% had a missing endoscopy. So what can we conclude from this study? Well, it seems like disease location, rather than severity, is an important factor for inducing mucosal healing. And specifically in this study, as in the Versify, it showed that small bowel healing may be more difficult than the colon or the rectum. Differences for this could be because of microbiota differences between the small and large bowel, possibly genetic differences as well. But hopefully more to come on this in the future. Thank you so much for having me, and I'm looking forward to a great discussion.